Is it up? Hey everybody, welcome to Fertility Fact or Fiction. And we have another amazing show with a really interesting article for you tonight. So we're super excited to share that with you. We're just going to give everybody a chance to jump on board. I'm going to sip my tea and we'll talk about the world and things like that until everything gets ready. So thanks for joining us and welcome to another episode. And now I've got a great big glob of tea on my tray. It's been a great week already. We've been super busy and worked through the whole weekend. Loads of patients from Europe that we've been helping, lots of patients locally as well, and really honored and glad to have the opportunity to reach out to so many people. A lot of people reach out to us on Instagram or Facebook just asking for help, and I'm always happy to help. So if you need help, don't hesitate to reach out and we'll do what we can for you. And tonight's topic is whether or not you can predict if you're going to have embryos to freeze. And it's a really great topic because obviously it's important to know if you're going into a freeze-all cycle if you're going to have any embryos to freeze. So these authors wanted to look at that and see if they were able to predict that with a reasonable degree of accuracy or a high degree of accuracy. And so they accessed the SART database. So the SART database is the American database for all fertility centers that do IVF. It's mandatory reporting. And so they collect quite a large amount of data every year, and you can access that data as a research project and then go through questions that you want and review them and assess them and then present your data, obviously, in a research study. So that's essentially what these guys did. They were from the University of Utah. They made the application. They went through the data. So are we up and we're good to go? Perfect. All right. So hopefully you're all on board. And feel free to throw up any questions as we go if you have questions about the study, and we'll do our general answer section later. So this study basically was done in 2014. So it is a little bit concerning that it took them from 2014 till now to figure this all out. They don't actually explain why that was the case. The study specifically looked at people that were doing freeze-all cycles. So as many of you know, frozen seems to be a little bit better than fresh in many aspects, and in many patients, not necessarily everyone, but in many patients it is better. And so with that in mind, these authors wanted to say, well, can we validate or estimate whether or not at the start of your cycle or before your cycle, you're actually going to end up with any embryos to freeze? Super important question, because obviously all of you guys want to know, are you going to be successful and have any embryos to freeze, or are you wasting your time with this, or should you consider doing a fresh cycle because maybe you won't have any that make it to the freezing stage? So they took all of the SART cycles that were doing freeze-all, none of the ones that actually ended up already with a frozen embryo transfer, and they did exclude people that were doing PGT-M, which is when you're looking for single gene disorders, because that's a really different population. They may be more complicated, and they didn't want to skew the data. So they said, okay, we're going to exclude those people, but we're keeping everybody else in the mix, and it just takes kind of everyone. So one of the important things about this is how discriminatory their data is. And so they used something called a C statistic. A C statistic is an analysis of how predictive or how valid the assessment model is. So if you get a value, they say, that is less than 7, it's no better than flipping a coin. Or sorry, if it's equal to 0.5, it's no better than flipping a coin. If it's less than 7 to 8, then you're looking at an acceptable level. If it's between 8 and 9, it's really excellent. And if it's over 9, it's outstanding. Anything over 7 is considered clinically acceptable and valid and useful. And getting it over 9 is like impossible. That's the unicorn. Those don't exist. So essentially, these guys went through large data sets. So we're going to show you the first chart, which is that box graph. I'm hoping, but I'm not sure it's up or not. Is that available? That would be this guy here. Can we get that? All right. So this is just the number of patients that were eligible, and you should be able to see it on the screen in just a second. So they had 141,020 cycles that were patients and cycles that were eligible. They had to exclude quite a lot, 109,000, because they had already gone through FET. Some of them were frozen embryo, or sorry, some of them were PGT-M cycles, and some of them actually went on to have a fresh cycle instead of a freeze-all. So available for analysis was 31,537. You should be able to see that on your screen now. I'm assuming it's off to my left, right? Over there. There you go. And so they had to exclude another 15,144 because they were missing some of the factors they wanted to use as part of the prediction model, including AMH or where the region was in the US, but the region was only 2 cases, so that didn't matter very much. So in the end, they included 16,393 patients, and they used that for both the development of the model and for the validation of the model. So the next little graph, table 1, is the first one you want to look at. And that's going to come up on the screen just to my left there as well. And so here what they did was look at the factors that showed discriminatory prediction value in their model. So they looked at a whole bunch of different things and they said, okay, in our analysis, here are the factors that are actually predictive. So what are they? They are age, AMH, and the number of eggs that you retrieve at the time of the cycle. So unfortunately, you can't actually predict with this particular model prior to starting the cycle, but you can predict at the time that you at least go through the IVF if you're going to end up with embryos to freeze potentially, or at least that's what their data is suggesting. So in regards to age, if you compared the patients whose age was less than 35 to all the other groups, if you were 35 to 37, your chances went down about 36%. If you're 38 to 40, your chances went down about 62%. And if you're 41 to 42, 75%. Over 42, it is an 88% decrease in the chance you'll actually have embryos to freeze. So those are all very highly statistically significant numbers because they have this big data set of 15,000 patients. And when you have those kinds of numbers, you get these incredibly highly valid statistical analyses. When they looked at AMH, obviously you guys know what that is, anti-Müllerian hormone. It's the best test we have for predicting how strong the ovary is. It doesn't always mean you have to rely on it, but it is a very valuable test for us. So compared to patients that were between 1 to 3 nanograms per mil, if you were less than 1, it was a 71% decrease in success. If you were over 3, you had a 160% increase in success. And so really robust data there to show that the higher your AMH is, the better, and the lower your AMH is, the worse off you are. They broke down the eggs into different categories. So there was 0 to 3, 4 to 8, 9 to 13, 14 to 20, and then greater than 20. And so when they compared it to the 0 to 3 group, so the lowest number of eggs retrieved, it's really very impressive. So you've got an 700% increase if you are 4 to 8. 9 to 13 was a 19.5-fold increase. 14 to 20 is a 44.9-fold increase. So that's essentially 450%. And if you are looking at, that's 4,500%. And if you're looking at 21 to 45, it was 106.8-fold increased risk that you'd have some to freeze. So obviously when you're getting that many eggs, it's very, very likely you're going to end up with some kind of embryos to have left over for frozen. Can you pull up table 2? So table 2 was the predicted probability of having 2 or more embryos cryopreserved by age and AMH. So when they just looked at your age and AMH, you can see that they broke it down into those 2 categories and then little subgroups. So if you're less than 35 and your AMH is low, less than 1, you've still got a 41% chance you're going to end up with embryos. If you're less than 35 and your AMH is average, 1 to 3, you've got a 68.95% chance you're going to end up with frozen embryos. And if you're less than 35 and greater than 3, it's an 83.2% chance you're going to end up with frozen embryos. So those are all like really pretty decent numbers. Obviously, when you're less than 1, it's not wonderful, but if you're less than 1 and you have low AMH, you're still getting a 41% chance of frozen embryos. That's actually pretty reasonable as far as the medicine is concerned. And you guys can see the rest on the screen there. 35 to 37 in that low AMH category, you're 39.2%. If we go to 35 to 37 over 3, it's an 82% chance. So very, very good numbers there. As you get older, you can see that the risks go down. The ones that are really important are when you hit 41 and 42 and your AMH is low, you got only about a 27% chance. When you're over 42 and your AMH is low, you only have a 16.7% chance. But if your AMH is high and you're over 42, you actually have a 58.7% chance. So we're going to flip to table 3 in a minute, but the numbers here are showing very reasonable, robust outcomes if you have a low AMH, if you have a high AMH, but your age is still increasing. But conversely, if you have a low AMH at any age, the results are not that robust and they certainly decline significantly over time. And so you have to factor that into the model. So they then took this and they said, okay, let's come up with some sort of scoring system we can use to help clinicians like me so that when I'm talking to you, I can tell you what kind of numbers we're going to look at. And that's in table 3. So table 3 shows the points that are awarded to your age, your AMH, and the number of eggs in those categories we had discussed earlier. So if you're age less than 35, that's the reference. So they said you're a 0. For every couple of blocks of ages you go up, it goes up. So 35 to 37, you get a 0. 38 to 40, you get a -1. 41 to 42, you get a -2. And over 42, you get a -4. When your AMH is less than 1, you get a -1. 1 to 3 is 0. Greater than 3 is 0. When you've got 4 to 8 eggs, you get a +9, and then it goes up to +12, +16, and +19 for those 21 to 45 eggs. So they just came up with these numbers, their scoring system, and then they use that data. So the next table that you look at is essentially table 4, and on table 4 they've got this great data that basically says take the score, plug it in into this kind of table or chart that they have, and it gives you the percentage. So I won't go through it all with you because it's like loads and loads of numbers. They've actually got 24 different numbers from 0 to 24. But essentially, if your score is a 0, your probability of having 2 or more embryos to freeze is 3%. If your score is a 5, it's 10%. If you go up to 10, it's 28%. You get your score of 15, now you're at 58%. 20, you're at 83%. And if you're over 20, it's really getting up into the high 80s and even the mid 90s. So again, you can take these values from your data set and that'll help you predict how you're going to do at the end. Now, keep in mind, these are predictions, and it's not 100% accurate. So their C statistic was quite reasonable, but it's not 100% accurate. This is not a 0.9. They're getting a 0.72 C statistic, which is just over that threshold of what's considered clinically acceptable. And so it can help you predict, but I don't want those of you that end up with these numbers at the start of a cycle, or sorry, at the egg retrieval, to turn around and say, oh my God, I'm not going to end up with frozen embryos. That's actually not the case. You may fall outside of that prediction and do totally fine. And conversely, some people who actually have a good prediction may actually not do well at the end and not have embryos to freeze. So the study is really quite robust based on its numbers, and it's very useful data because you can actually take this table. I plan to kind of make it very large and keep it on my computer screen and score this for people so that I can turn to them and say, hey, if you're wondering what our prediction is, we can actually hand you a number and say your prediction is 53% or your prediction is 60-something%. So, you know, you can go home and feel more comfortable that you're going to actually end up with what we were targeting from the beginning, especially, and keep in mind, this is 4 freeze-all cycles, so that we can reassure you that despite the fact we're freezing all the embryos, you're going to end up okay. So is it a fact or a fiction that we can predict? Well, it's a fact that we can predict, although you do need to be cautious about how accurate the prediction is. It's reasonably accurate, it's acceptable, but it is not excellent or outstanding. We would probably need either more data points or a better prediction model, which they weren't able to generate here. So remember, fertility is never cookie cutter medicine. We're making babies, not cookies. And so we don't just, you know, figure this all out by plugging in a couple of numbers like you do the ingredients for a cookie. You got to make sure you're understanding that each patient is an individual. Each patient will respond differently. And because they'll respond differently, you need to make sure that you're treating them as individuals and giving them results that are going to be reasonable, rational, and help guide them, but never take away anybody's hope, because we actually don't know. You get patients that do natural IVF cycle, make just 1 egg, and end up with a baby. And I've had that so many times I've lost count, which is why I like natural cycle IVF. And then you get other patients that can make 20 eggs and unfortunately don't end up with any reasonable embryos. So it's a valid model. It can be predictive, and it can certainly help guide patients, but we're not going to say that it's 100%, and this isn't something that you kind of say to every patient, hey, you've only got a 20% chance, get ready for your next cycle, because that may not be the case for you. So thanks for joining us. Make sure you comment, like, share. We'd love to hear what you think about the prediction model. Do you guys want this kind of information when we're doing your IVF? Do you want me to tell you after we've retrieved the eggs, hey, you got 12 eggs or you got 14 eggs, you're going to get a chance at freezing that is this high? I think it's great for us to get that feedback, because then we know what to do when we're talking to you and other patients, and we really can value that and incorporate it into our practice. So we're going to start taking questions now and do the regular part of the show. As always, feel free to ask your questions. We try to get through as many as possible, and Tarek's going to start firing them off shortly. You can ask on YouTube, you can ask on Facebook, we're on Twitter, and we're also on Instagram. So any of those services, you're free to put up the question. We'll get it here and we can read it off and answer it.
First one off Instagram. Are you able to explain the difference between IMSI and ICSI? Do you do IMSI?
Yeah, we don't really do IMSI because it's a sperm prediction or selection process, which has not demonstrated any significant benefit in any study that has looked at it. So there's no evidence that IMSI is superior to ICSI in any category. So I don't believe in doing things that have not shown that they're at least superior, especially when they're adding cost, because it's not actually helpful. So it's just a specific methodology used to select the sperm. And there's all sorts of these things. There's like piezoelectric fields that they're using to select the sperm, and there's IMSI. There's all kinds of things, but we don't actually do that because it doesn't actually change the outcome. ICSI versus IMSI is going to give you the exact same outcome from every study that's available so far.
I'm not sure if you already addressed this. Does a PGS normal embryo drop in its embryo grade? does embryo grade still play a role in a PGS, normal embryo, and implantation success rates? Thanks.
Yeah, so it still does. You can have a genetically normal embryo that is horribly energy inefficient or, lacking in appropriate organelle structure. And so there is some impact of that. Now, generally speaking, and there are studies that have looked at this, the embryo grade, which is highly variable between embryologists. So if you sit 10 embryologists in a room and say, look at the same embryo, you'll get from A to Z in your grading. So, it's very variable in that regard. And so it's hard to kind of research this appropriately and quantify it the right way. But the answer is yes, there is some impact of embryo grading that is still relevant even if you're PGT tested. And actually there's a study on that, I think it was out just about 6 weeks ago, which demonstrated that. It actually supported the fact that your embryo morphology is still relevant even when you have a PGT tested embryo, but not as much as you would think. And it's only relevant when the quality is really bad. So if you've got a genetically normal embryo and it's like a BB or a BA or AB or an AA, they don't actually differ very much. They're all going to do the same. But if it starts getting below that BB level, they are demonstrating that the morphology can have an impact. So that's important for you to know, because you can't ask for your embryo grading, especially if they're going into a freeze-all, and that'll help you decide what to do. Great question.
Hey, Dr. Victory, did you get the Pfizer vaccine or the Moderna vaccine?
I got the Pfizer vaccine, and I had a tiny bit of pain, and then that was it. So that night it was kind of sore. I took a couple of Advil. I slept on my right side instead of my left side. And as I mentioned in my post, I have not grown a second head. I'm too old to try to be fertile, but I'm sure it hasn't affected anything, and I honestly haven't felt different than I did before. So I'm perfectly fine. Nothing has really changed for me.
Dr. Victory, how soon after stopping progesterone should I expect to get my period?
On average, about 3 or 4 days. So if you're taking progesterone and you want to know how long, usually it's about 3 or 4 days, and 3 or 4 days into it, your period should start coming. If it doesn't, it can take a little longer in some women, but you definitely want to get checked out and make sure maybe you didn't have a false negative beta, or maybe you are pregnant already and didn't know it. So make sure you get seen and evaluated if you're not having a period. It's been more than like a week, 10 days after you stopped your progesterone.
Hi, Dr. Victory. My question is, I took Provera for 10 days and haven't had a period or bled at all. It's been over 2 weeks since I took the last pill. What do you typically recommend when this happens?
Sure. So fantastic question. That's really good to help everybody with. So thumbs up for that one. Thank you. Kind of a nice segue from what I was just talking about, actually. So that's perfect. So if you don't respond to a progesterone withdrawal test, essentially one of 3 or 4 things has happened. So number 1, you're pregnant. So you have to get a pregnancy test, because that's often the case. Number 2, it could be that you did not have enough estrogen. And so despite the fact that you took the progesterone, your body's not responding because there's no lining to shed. So you just have a thin lining. The other possibility is that there's an obstruction. So whether there's scarring in the uterus or your cervix is so tight it's blocked, the blood's just not able to come out. That's typically painful and very crampy, and so people kind of know when that's the case. And you'd probably have a history of recent cervical surgery or a recent infection in the uterus, or a scar from the uterus because you had a D&C and now you've got Asherman's or something like that. The one rare occurrence, which I've only seen once, is that, and it's mentioned in one of our REI textbooks, is in Spiroff, is that you can have the very, very odd case where someone is so PCO that their testosterone levels are so high, their lining is hyperandrogenized, meaning it's been exposed to too high a level of male hormones, and so they're not going to respond to the progesterone because it's just dominating the estrogen effect, and so you're not getting a lining developing. So you're either pregnant, you're either not producing enough estrogen, you're either not being able to release the blood, or in that super, super rare case, there's too much testosterone on board. Those are the only 4 things, generally speaking, that can cause that. So you need to get checked out and find out why your specific case is going the way it is.
What is a typical endometriosis protocol at your clinic? Thank you.
Okay, so I believe in kind of holistic care. So we use our whole team. Our team is myself, of course, my nurses and staff at the office, but we also use our naturopath and we use our incredible pharmacy. So we approach endo from multiple different aspects. So in the days before COVID, surgery was definitely something that we offered to patients and that we recommended in many instances, because unless you've got stage 4, it's actually quite reasonable to clean spots of endo and improve your chances. And I've got videos on YouTube that you guys can look at. We have a whole half-hour video on endo where you can see me removing a cyst or just burning the spots and seeing what's involved. So surgery is a very valid model and applicable to cleaning up endo, and it does definitely benefit and alter your outcome. If we're trying to skip surgery, or in COVID days, the most appropriate approach based on my knowledge, and we've shared this on a previous video with Factor Fiction, oh boy, probably last year, guys, and throw some thumbs up if you watched that video and you liked it, is that you can put Lupron with letrozole for 3 to 6 months, and that essentially almost normalizes your chances back to baseline level. And Lupron plus letrozole is actually better than Lupron alone. So those 2 together can be very helpful. Following that time period, when we're getting you ready for your actual transfer, we try to use as little estrogen as possible, and we keep you on the medications that we need, the supplements that we need to make sure that you're doing everything you can to keep the endo quiet. So that would be NAC, which is N-acetylcysteine. That would be turmeric or curcumin. And that's from our great naturopath, Jen Strong, who recommended that. And it also is, again, in another one of our videos where we reviewed natural products that work for endo. And then you can also use any other antioxidants, so things like the fish oils, omega-3s. You can use coenzyme Q10, vitamin D, vitamin E, any kind of antioxidant, vitamin C. So all of these we use to try and improve the outcomes for our patients, because those natural components can suppress some of the inflammation caused by endo. And the more we suppress the inflammation, the better we're going to do. So that's our general approach. We are very careful about our lining for our patients. We want to make sure they're not contracting. We do sometimes extend by a day to get the progesterone level high enough to suppress endometrial contractions. We are still following the compaction of the lining, although there is a recent study coming out that says it doesn't make a difference when a previous one said it did. Welcome to the wild world of IVF. And so we look at all of those things, and then I am super cautious when I do my actual embryo transfer. In particular, in a patient with endo, use a small warmed speculum. Make sure you're being as gentle as possible. A lot of endo patients get a uterus that's kind of pulled backwards, a retroverted uterus. And when you have that retroverted uterus, it's very difficult to see abdominally. Most fertility centers will therefore take the ultrasound probe, put it on the woman's tummy, and then essentially try and push down through the bed and pulverize you in an attempt to get a clear picture. Clearly, by that time, for someone with bad endo, they're already crampy and in pain and nervous. You're just making it worse. So what we mastered was doing transvaginal ultrasound guided embryo transfers, where you don't have to hurt the patient at all. You get the clearest view possible, and you don't even need to have a full bladder, and there's no pressure, there's no driving your ultrasound probe through the patient's spine. You're just treating them like wonderful human beings. It's super gentle, crystal clear imaging, very, very nice embryo transfers. Very technically sophisticated. I do not know a lot of people that do it, but there are a few out there, and we definitely mastered that technique, so it's something I'm very, very comfortable doing. So that's our basic protocol.
What do you think about receptiva tests, and is it accurate?
Okay. So we get asked about Receptiva and Era every show, and I love talking about this because they're useless. So Receptiva has absolutely no support for its use. It's not a valid or useful technique. And even more so is the endometrial receptivity array. I actually now dislike that test so much that I was actually going to present tonight's topic as the ERA, because there are 3 more studies all demonstrating that there is absolutely zero validity or use for that in almost any circumstance, even in the patients that have had recurrent implantation failure. So the Receptiva test is not useful, and nor is the ERA test. We're looking at the utility of doing Matrix, which is an ultrasound only test. I don't know yet, so I'm going to reserve my judgment. We're going to test it and see if it makes sense. If it makes sense, we'll definitely bring that to you in another presentation. I do know that there is one place in Toronto that's using it regularly, and apparently the doc that's using it is getting significantly better success than the other doctors. But admittedly, I'm actually getting that success rate without doing the Matrix. So it's kind of hard for me to know if that's going to benefit or not, but I'm certainly willing to give it a shot because it's harmless to the patient. And so it's just an ultrasound, and they can actually score it based on criteria they've developed to tell you if your lining is actually appropriate for implantation or not.
Do you recommend removing endometriosis before retrieval? Do you find a negative outcome with AMH number of embryos collected after surgery?
Yeah, so that's a fantastic question. So the question is, should you have your endometriosis surgery before your egg retrieval or after the egg retrieval? And does the surgery before the egg retrieval impact the chances of retrieving enough eggs to make embryos? So answer to the first part of that question is, I actually recommend doing the surgery before the embryo transfer. And I believe there's logic behind this. When we're doing your stimulation, we're driving up your estrogen level. When we drive up your estrogen level, we're stimulating the endo. And no matter how good a surgeon you are, you will never get rid of all the endo. So if you leave some behind, even accidentally, because it's too small for you to see, while you're doing the stimulation, you're actually firing up that endo. So it makes more sense to do your retrieval, get the eggs out, make your embryos, and then go ahead and operate on the patient, because then you've optimized the environment the embryo is going into, which is actually the time that has the most impact on the success of your IVF. It's not so much on the quality of the eggs and the embryos, it's much more on your implantation potential. So that's the part of doing the surgery timing wise. From the standpoint of patients that have endometriomas, so cysts of endometriosis, there is a lot of data that supports the fact that if you take out the cyst of endometriosis, you will compromise the number of eggs that you can retrieve. The patient's AMH will go down and so on. So there's a couple of things about this that you need to know. Number one, it's transient, and after a year, it's no longer valid. Their AMH is normalized. Number two is that those patients that have big endometriomas have higher risks of complications, including infection, spillage, which causes enormous amounts of pain and further potential spread of endometriosis. You can have difficulty retrieving eggs that are behind the endometrioma, so you may miss some of your eggs. So depending on the size and the location, you have to really individualize that determination. The other problem with all the studies that are done on cyst removal for endometriosis is every surgeon is highly different in their technique. So when you remove an endometrioma, and if you watch that YouTube video we have on endometriosis, you'll watch me very carefully pulling the cyst millimeter by millimeter, literally, away from the ovary. And I've only made one little cut in the ovary, so I'm not taking any ovarian tissue with me. I'm leaving the ovarian tissue there intact. I'm just taking out the cyst. So under those circumstances, it actually shouldn't impact anything. And the bigger the endometrioma gets, the more pressure it applies on the cortex, the outer shell of the ovary. That's where your eggs are. When you start applying pressure, you reduce blood flow. Reduce blood flow, you're going to get less eggs for sure. So there is a disadvantage to leaving endometriomas there, because multiple studies show that the endometrioma itself reduces the number of eggs that you have. So I hope that answers your question. Fantastic question. Thank you for asking that.
I met with you. I met with you next month for the first time. I met with you last month for the first time on Zoom. I would like to get a sono done with you. What is the wait time for that? Thank you.
Oh, just call us on the first day of your period. We can usually get you in that month, and if not that month, for sure by the next. So there's not really much of a wait time at all.
Hey, Dr. Victory, can you speak much to the results of a NT test? Trisomy 21 results have come back as 1 in 4 as adjusted risk. And NIPT is being done and waiting for those results to continue with
Amniocentesis. Yep.
Can you speak to any experiences you have seen with odds like this?
Yeah, I mean, the reality is your odd is your odd. So you have a 25% chance that the baby has Down syndrome. So I'm sorry for what you're going through. I know that can cause a tremendous amount of angst and concern. So when you do a nucleotranslucency or early first trimester screening test, which includes the nucleotranslucency, they screen you for multiple different conditions, the main one of which is Down syndrome. And if your screen comes back higher than certain thresholds, depending on where it's being done and what their threshold is, you will screen positive. Now, keep in mind, it does not mean that your baby has Downs. A positive screen can be 1 in 350. So that's a 0.3% chance that your baby has Down syndrome, but it's a positive screen. So in your case, the chance is moderate, and obviously there's concern. But I've had babies that scored 1 in 3 and didn't have Down syndrome. So keep in mind, you've got a 75% chance your baby's perfectly normal and a 25% chance that there's a problem. Your NIPT test is pretty accurate. It has an error rate of 1 in 10,000. So if your NIPT comes back saying that the baby does have Down syndrome, unfortunately, it's very likely that it does. They do, however, not use NIPT as a diagnostic test because they say that it isn't truly diagnostic. It's still a screening test. They always want to confirm with the amnio before they go ahead and do the termination, if that's what you're choosing, or advisement that the baby genuinely does or does not have Down syndrome. So I'm so sorry again for what you're going through, but those are the numbers. So we have loads of babies that score 1 in 8, 1 in 10, 1 in 5, 1 in 4, 1 in 3 even, and they've come out completely fine. So best wishes and good luck. I hope that works out for you.
A week or so ago, you mentioned how it is dangerous to not getting regular periods.
Yeah.
My family doctor told me this isn't something to be too concerned about as long as I was cycling a few times a year. I see most of content is based on trying to conceive. Do you take referrals for women who are currently trying to conceive but are having cycle issues?
Yeah, so of course we take referrals for any patient that's suffering from any reproductive endocrinology or infertility problem. So if your cycles were irregular from PCOS, we're happy to see you. With all due respect to your family doctor, that family doctor is just flat out wrong. So you having a period every few months is likely not ovulatory. It's just that your lining's getting so thick it's shedding, which means that you are chronically exposed to very high levels of estrogen. Those high levels of estrogen, we know, place you at risk for diabetes, for heart disease, for insulin resistance, which causes the diabetes and the heart disease. We know it places you at risk for having breast cancer potentially, and definitely at risk for developing endometrial cancer, maybe even ovarian cancer. So they're flat out wrong. It's incorrect what they're saying. It is not safe for you to have a period once every few months. You must be regular, and regular means less than every 35 days. If it's not every 35 days, those are prolonged periods of estrogen exposure. That is 100% not safe. Now that's assuming that you are polycystic ovarian syndrome. If your period is irregular because of another reason, you're exercising too much, you're too thin, there's an eating disorder, you have menopausal or perimenopausal status, those aren't necessarily dangerous. The eating disorder one is, but they do have side effects. So you can get bone loss. You can have problems later on in life because of the bone loss. If your estrogen level is too low instead of too high, that can leave you susceptible to heart disease as well. So you do need to be judicious about how you approach this, but there's no question that it is not safe to have irregular periods if you're PCOS, and it's probably not that safe even if you're not PCO and they're just irregular. You need to find out why.
Did the little yellow car fall off the wall?
The little yellow car fell off the wall. Thank you guys for noticing. I was hoping somebody would notice it. My Porsche was on the floor this morning. It's not actually my Porsche. This is like a $250,000 car. So this is a GT2 RS, which is a super cool car. Maybe in my dreams, but otherwise just something I have on my wall. So I didn't have time to stick it to the wall again because my multiple layers of Velcro wouldn't stay. Yeah. Great. I love the stuff people notice. That's hilarious.
Can you still get your period after getting a Lupron injection?
Yes. So if you do it on day 21 of your cycle, you should actually get your next period. And occasionally women will break through again in a subsequent cycle, even if you've had the 3-month depot Lupron injection. After that, it's typically not very common unless the Lupron's not working for you. But most of the time it'll suppress you enough that you should not get a period after that first one.
Do you prefer HCG-LH or Menopur?
HCG-LH or Menopur? I'm not familiar with any product called HCG-LH or Menopur. I'm not totally sold on the whole take LH thing, like recombinant LH in the form of Luveris. There's no data that says that it's better. We always mix Gonal-F and Menopur is contaminated with HCG. So you get a little bit of an LH effect, and it's just enough that it gives you that LH effect you're needing. In our experience, it's always resulted in very, very good egg and embryo quality. So that's what we use.
Well, there's a conversation here. So the one girl asks, is the yellow car fall off? And somebody respond, it's chilling with the chocolate to the left.
Good eyes, yeah. Lindors, I would be happy to share with you guys, but I can't through the camera. And I don't get any advertising promotion from Lindor. I actually had it sideways, so I'm impressed someone noticed that. Yeah, I also don't have any sponsorship from Porsche, although I wish I did. I don't own a Porsche, guys, in case you're wondering. Yeah.
I have a laparoscopic surgery on January 22nd. When it is considered safe to start trying to conceive again?
Right away.
I will be added to the funded IVF wait list after receiving my results from this surgery, and the wait list is 6 months. Should I be going on medication to suppress endo during the wait time? How long does endo typically take to come back?
Okay, wow, that's a lot of questions. Okay, so number one, congrats on getting surgery, but don't count on it occurring because of the crisis and the government basically saying stop doing surgery. So that might be a bit of a problem. Number two, you can start trying right away, and if your funding is in 6 months, which doesn't actually make sense because all across Ontario it's almost a 2-year wait. So if somehow you manage to get funding, maybe your turn had come up and it's going to happen in 6 months, then I would say try for 3 months and then go on the Lupron and the Letrozole for 3 months and then do your frozen embryo transfer. So that's probably your, oh, actually, sorry, you're going for your IVF. So try for your 6 months. You can use Vizan for 3 months prior to your egg retrieval. That's been shown to be beneficial. We have that in a factor fiction from about 6 weeks ago. And then once you've done that, make sure they freeze all your embryos. Please, please, please do not do a fresh embryo transfer. It doesn't work in endometriosis patients. And then go ahead and do the Lupron and the Letrozole for 3 months and then jump into the next frozen embryo transfer that you can, and you should have a very reasonable success rate.
They're complaining I'm not loud enough.
All right.
So I'm going to try and be louder.
We're going to need a mic on you.
That's what it's
Can we double mic?
We'll double mic.
We'll double mic. We're going to double mic.
You talk about avoiding caffeine, saying it's a higher chance of miscarriage.
Yeah.
Is that all forms of caffeine, or just caffeine? Is green tea safe? Matcha tea safe?
It's any form of caffeine. So there are studies, large studies, that have demonstrated that if you're consuming more than one caffeinated beverage per day, there's a small increased risk in your risk of miscarriage. So it doesn't matter what kind of caffeine. It could be hot chocolate. You don't want to have more than one caffeinated beverage a day. So drink decaf or just have one.
Any concerns of IVF babies at a higher risk in regards to COVID-19?
No. We got to get you off your knees, man. You're going to
I'll be
die.
fine.
You're
I'll
going to
be fine.
die on the...
No,
No, you
I'm
can't.
all right.
Just pull up the chair.
I'll after the questions. There's a lot.
Well, you can just shout.
I tried that.
Okay.
Does having sex on the day of IUI increase the chance of conception?
We think so.
What days should we be having sex during a letrozole IUI cycle if male infertility is not an issue? Thank you.
Every 2 days, you should have sex throughout the whole month leading up, and then hold off around a day or two before you're actually doing your IUI. And then if you do it again right after your IUI or before your IUI by 3 hours, that's actually okay, because actually the second sperm sample within 3 hours of the first one is actually better quality from a sperm DNA fragmentation assay standpoint. So either way is good. Probably have sex again the next day, and then after that it's mostly for enjoyment, it's not for effect. So if it de-stresses you, I'd actually encourage you to keep doing it, and if you're not a huge fan of sex, then maybe chill out and watch Netflix without the chill.
You suggested knee surgery for laparoscopic myomectomy, and you did so. What is the next step to conceive? I'm 38 years old. Thank you.
So if you're 38 and you're trying to conceive and we did a myomectomy on you, go ahead and try if there's nothing else that's wrong. If you're 38, I'd probably recommend like 3 to 4 months. And then if it's not working, come back and we'll start helping you with either pills and insemination, shots and insemination, or IVF. So you have lots of choices.
I asked a question about Provera and not getting the period over 2 weeks
Yeah.
earlier. If the cause is not enough estrogen,
Yeah.
is this still related to PCOS? Does it typically take long to get the estrogen back up, be able to get a period?
So if it's related to PCOS, it's definitely not low estrogen, it's high estrogen, unless you're that hyperandrogenized person. Even then they tend to have high estrogen. But it's not going to be a low estrogen problem. If it's because of low estrogen, it's probably that your ovaries are beginning to decline and function. So it's either perimenopause or premature ovarian insufficiency, or something weird going on where you could have like Cushing's disorder where your hormones are just getting suppressed so that they can't respond. But you need to get that checked out. It's important to figure that out. Instagram. We always got questions on Instagram.
Is it true that transferring more than one does not increase the chance of success?
Okay, so last year I reviewed a study which I actually think of all the time because it had something in it that was totally mathematically bizarre but nevertheless true, and it made sense. So they showed that if you transferred 2 embryos at a time compared to 1 embryo at a time, 1 embryo at a time cumulatively had a higher success rate than 2 at a time. I'm not sure why that was, but it was actually a well-done study, and so even they recommended 1 at a time. Look, guys, everybody wants success, so they think, put in more, you're going to get a better success rate. The previous place I worked at loved to put in multiple embryos. In fact, he kept freezing them in pairs even when we didn't want that, because of the fact that he felt strongly that it was better when you put in 2. And you know what? He's right to some extent. You get a better result in some cases, not all cases. Kind of a shorter term to getting to that success rate potentially. The problem is if you do get twins, and it often happens, it's an 80% divorce rate. So it has a significant impact on your relationship. It has a very high risk pregnancy, and you can deliver prematurely anywhere from 23, 24 weeks where it's God forbid, disaster, up to, 35, 36 weeks where the babies are fine, but they're still in the NICU. You got to go visit. Now there's COVID. It's a nightmare. So single embryo transfer for the majority of patients is the way to go. There are exceptions, of course. If you've failed multiple previous single embryo transfers, sure, it's reasonable to put in two. If you don't know the genetics of the embryos and you're 38, of course, it's reasonable to put in two. It might even be reasonable to put in more if you're up into your 40s and you don't know the genetics. But these days we try and avoid that, because if you're over 38, we encourage you to do the PGTA, and that way you know if the genetics are normal or not. So great question. But like I said, you got to know sort of what's going on there.
Is there any new data on thin PCOS when it comes to IVF?
Not that I'm aware of. Those patients tend to do very well. Egg quality can be compromised. And so you want to make sure you are treating them with the supplements and stuff to reduce that endometriosis effect, PCOS effect. So you want to be on the NAC, you want to be on the inositol, you want to be on the coenzyme Q10, vitamin D, omega-3. Go for those supplements, guys. They do actually cumulatively probably make a bit of a difference.
My egg retrieval was canceled due to lack of egg growth.
Sorry.
My AMH is above 3 and my age is 33. What recommendations would you give to increase follicle growth prior to my next retrieval?
So you were probably oversuppressed if you were on the birth control pill prior, or overstressed, or there was something wrong, like you had a cyst at the start and they ignored it, but it prevented the eggs from growing. So if your AMH is if your AMH is 3 nanograms per mil, you should have a reasonable response, because that's actually like on the high side of AMH. If you're talking about 3 picomoles per liter, that means your ovary is in trouble. It may actually be quite difficult. So if that's the circumstance you're in, there are techniques we can use to try and help you. You probably are not going to get a lot of eggs to grow. Those are often the cases where I recommend just doing natural cycle IVF. You don't have to spend a ton of money on the meds. You don't have to go through all the shots as much. It's a lot easier on your body. It's definitely a lot easier on your wallet. We only charge $6,000 for that, so it's relatively, cost effective for the patients that need it. I don't want to say cheap because it's $6,000, but it's a lot cheaper than doing the full IVF. And so there are different ways to help you. If you still want to stim, testosterone priming has been shown to be potentially beneficial. Loads of vitamins, maybe acupuncture, see a naturopath, traditional Chinese medicine. There are tweaks we can use. DuoStim may help you, where we do the 2 back-to-back cycles. Again, we've got a YouTube video. We'll put the link up for you when we post this, and you can see it there. So that's up on the YouTube channel for us as well. So there are different ways to help you, but it depends on whether you meant 3 picomoles per liter or 3 nanograms per mil, because those are 2 totally different numbers. 3 picomoles per liter is very low. 3 nanograms per mil is actually kind of high.
Based upon the study, if I'm 44 and my AMH is 1.4 and I have 10 mature eggs, what is my chance of having a good embryo? And have you worked with 44-year-old patients that want to use their own eggs? Thanks.
Yeah, we've worked with patients that are 44. The problem isn't just what's here. Keep in mind, this was just showing you how many embryos you had to freeze. It does not tell you if the embryos are genetically normal. At 44, let's do some backwards math. And we have a video coming out soon. When do you think that'll be ready? Next week? So we have a great video coming out separate from Refractor Fiction called Embryo Math, where I tried to actually go through exactly that question. So we need to kind of go backwards in order to figure this out. So at 44, about 80 to 90% of your embryos will be genetically not normal. Let's be conservative and say 80, although it's actually probably more like 90, but let's be happy about this and take the positive approach. So at a minimum, you need 5 embryos to find one that would be genetically normal, because 80% would be 4, so 4 are going to be abnormal, 1 might be normal. Now, granted, it doesn't actually statistically work this way, but I'm giving you the rough estimates of this, okay? That's to give you a 60% chance of a live birth. If you want an 84% chance, you need 2. So now we need 10 embryos. In order to get 10 embryos, you actually need 20 eggs because 20 fertilized embryos to get to 10 blastocyst embryos that you can biopsy. So 20 fertilized embryos means you probably needed somewhere around 25, maybe 24 eggs. So you actually need 24 eggs at 44 in order to get to the point where you may end up with the 2 embryos you need to get an 84% success rate. If you're just looking for 1 and that 60% success rate, it's obviously much less. But you got to understand that there's what we call an attrition rate at every step of the process. So I'm only going to end up with, 20% of my embryos being normal. Only 50% of my embryos are going to reach blastocyst. Only 90% of my eggs are going to fertilize to become an embryo that becomes a blastocyst that gets checked to be normal. So there's this loss rate at each step. So yeah, we work with patients that are 44. I have had patients that have had success, but it is much, much lower. And if you look at the studies of this where they honestly report their results, over the age of 44 or over the age of 43 even, your chances are very, very low, unfortunately. So they're slim. There is a chance, but it's low.
One day prior to IUI trigger, I had several follicles, some measuring over 18 and one at 17. Does the 17 millimeter follicle continue to grow and potentially fertilize?
Yeah, for sure. They all grow and fertilize. If you grew it to the next day, they're all growing and they all are within the realm of what's mature. No one actually knows for sure what the exact size is that's correct for IUI. There's a study coming out that I read that says that around 19 to 22 millimeters is the best size. So your 2 18s would have been 19s and your 17 may have been a 19, but it would be awfully close. And remember, that's just the best number. It's not necessarily not going to work if it's not quite that size.
How many plasma cells in a CD138 stain to confirm endometriosis?
Wow. There is no test for endometriosis other than looking at it surgically. All of those tests are meaningless. So there's all sorts of things people look at to say this marker shows this and that test does that. And, there's all sorts of tests that people claim demonstrates you have endometriosis, all 100% invalid. None of them are predictive of endometriosis with any degree of accuracy. The only way to detect endometriosis is to go in surgically. You actually have to biopsy the part that you think is abnormal, send it to pathology, and they have to see endometrial glands and or stroma in the tissue that they're biopsying.
Are there any risks of usage of HCG provision and Wellbutrin for the baby before and after it's born?
HCG provision?
Proviron, yeah.
I'm sorry, I'm not familiar with HCG Proviron. Wellbutrin, yes. So any SSRI has an increased risk of lung and heart defects in the baby. We always have to balance that risk against your mental health risks if you're not on it. Certainly if you can manage without it, you should be off. But if you can't, we got to protect your mental health. So, it's a balancing act. But we have to take priorities very seriously there because we can't compromise your mental health when we're going through this. Couple more? Is there a lot?
Yeah.
Okay, go ahead.
Can a past eating disorder cause fertility issues? And if so, how?
So eating disorders can, because they can diminish your ovarian reserve. When you are extremely suppressed in your hormones at a young age, which is typically when those occur, it can affect ovarian function. So it's through the hormonal suppression mechanisms. So yes, it can mess things up. One of my favorite patients previously had an eating disorder, and she had seen another physician and was unable to succeed. And then she saw us, and I literally said, go on the Krispy Kreme diet, but in a very gentle way. We got her to gain some weight, and she got pregnant off a Clomid. It was like easy. So there are ways to help those patients, but you need to be careful and you need to know what you're dealing with.
What's the chance to conceive naturally after laparoscopic myomectomy?
I can't answer questions like that, guys, because it depends on so many factors. What's the sperm like? What's your age? How many eggs do you have? What's your AMH? What's your thyroid like? Where was the laparoscopic myomectomy? Who did it? How did they do it? Et cetera, et cetera, et cetera.
Hey, Dr. Victory. I'm on my first cycle monitor with you. I'm closer to the Toronto clinic than Windsor. I want to do my first ultrasound appointment in Toronto, but wondering if I book my SIS in Windsor, will it be done by you? I'm very nervous as my first SIS was very painful and a very terrible experience.
So, yeah, you can come to me for the SIS and do the rest of your scans in Toronto. No problem. We're happy to accommodate that. I literally do 3 to 6 a day, and nobody ever complains about our SIS in terms of pain. At most, they'll get mild cramping. It's never a terrible experience. Watch our YouTube video. We have 15,000 views on it, where I'm doing an SIS and the patient is like completely quiet. And when we ask her if she's having any pain, she says no the whole time. So, it's not bad if you do it the right way. I have a post I put up on Instagram several weeks ago going through how to do it properly so you don't torture patients. 1 or 2 more.
Okay.
We're after 9, man.
That's your decision, right?
Yeah.
Nobody blame the DJ here.
DJ Tarek. I like that. That's actually good, man.
Hi, Dr. Victory. Is there a place I can check for safety of natural products? I'm specifically looking for DMSO rose cream and natural oils containing camphor for pain management on thumb tumor.
So DMSO makes you actually absorb anything you put on your skin. So that I probably would say no to. Your best bet is to talk to the pharmacy. If you are the patient I'm thinking that you are, talk to Kinga in pharmacy and ask her, and she'll be able to find out for you. She's spectacular. So she can find out. You could call Kinga in our pharmacy if you're not the patient I'm thinking of, and she'll still help you out because she's an amazing lady. So I don't know the answer to all of those, but there's certainly nothing wrong with taking pain meds. If you need them in pregnancy, you need them. So we do that all the time. Just stay away from anti-inflammatories, no Advil, Motrin, that kind of thing.
I have 2 failed HRT cycles. My period following the HRT both times was very scarce, barely there. However, always healthy, looking, and regular when not on it. Am I better fit for natural FET rather?
You might be. That again depends on a lot of features. Do you have endo? Have you had genetic testing of your embryos? What was the quality of the embryos? What was your transfer like? What was your lining like? Unfortunately, some of these questions are kind of tough to answer because I need to sort of be there and be in charge for you so that I can answer, what would be best for you. The natural versus hormone, replacement cycles are a huge controversy. Literally every couple of weeks, there's a study that says natural is better. And then a few weeks later, there's a study that says the stimulated is better. And then there's another one that says it doesn't make a difference. So there's no clear answer on this yet. Every month I read one study that says the opposite of what was said before. In fact, one night I read one article that said natural and I was thinking, oh, this is like a well done study. I should consider it. And then the next day they had one that said the exact opposite, like literally back-to-back days. So if you've tried 2 stimulated, it's not unreasonable to try a natural. We use a lot of tweaks that we've learned from actually doing this show to maximize our success rates, and our success rates are crazy right now. They're so good. So maybe just see if you can follow kind of what we do, and we can give you a good success rate no matter where you are. Are we good? I got a lot. All right, guys. So we're going to wind it down so I can get home to the family. Thank you so much for joining us. We love doing this show. Make sure you like, comment, share, subscribe to our YouTube channel. And I want to challenge you all to see if you can encourage some of your friends and family to jump on our Instagram account. We are trying to gun for 10,000 and we've got about 3,500 to go. So help us grow. That's always a great step forward for us. And check out our videos. They're all up there. We record all of them. We put them up. And Tarek's doing some amazing things with the graphics and so on now. So the show just keeps getting better and better. We'll see you next week at 8 o'clock on Monday, I believe. And have a great week. Stay safe. Wear your masks. Avoid touching people and close contact. Isolate and be really cautious, guys. And if you have the opportunity to get the vaccine, get the vaccine. We will likely be starting the pregnancy trial for the Pfizer vaccine very shortly in our office. So don't hesitate. There is no evidence it's harmful to patients that are young, healthy. There's no evidence of harm in pregnancy so far either. So I encourage you to get it. And I have not had any second shoulder or second head grow. Some days I wish I had, but it hasn't happened yet. Have a good night, guys. Take care. We'll see you later.